I'm really happy to be here, and I'm impressed by the number of people waking up so early in Athens, though there is a blue sky outside. I'm going to tell you my experience and data that we generated in my group on inotropes. Here are the conflict. Here's going to be my last slide, just for you to check that what I'm saying is correct or not. In fact, I'm going to start by telling you what is not indications for inotrope. I will start by the majority of the patients that we are taking care in ICU and say those patients, please do not use inotropes. And then I will speak about cardiogenic shock. Then you will not hear me speaking about septic shock. I would like to focus on cardiogenic shock, on patients admitted in ICU for cardiogenic shock. And I will show you that in patients with evidence of low cardiac output and acute myocardial infarction or post-CPR, we should first use inotrope and then norepinephrine if needed. I will show you the last recommendation on acute right ventricular dysfunction, where I would show you that the first agent to use is norepinephrine, just to make a difference between right and left dysfunction and cardiogenic shock, because some people may be confused and think that cardiogenic shock should be treated by the same way. And at the end, I will show you that really epinephrine is rather an issue in patients with cardiogenic shock and acute myocardial infarction. During my lecture, I will follow this paper that was published the last year. I really advise you to download this paper, who was written by people from all around the world who are expert in acute heart failure and cardiogenic shock. And in this algorithm, here we could show that a patient coming with acute heart failure should first be triaged to see whether he's hemodynamically stable, although in severe pulmonary edema, or hemodynamically unstable. I will come to this in a minute with cardiogenic shock. But let's say the patient is hemodynamically stable. There is or there is no respiratory distress, but clearly there is an acute heart failure. And you see here that within 15 minutes, we need really to take care of this patient, start medications, start also some lab tests, BNP, troponin. As you can see here, for the first time, we said that lung echo can help the management of those patients, because you can have some B-line that you can see immediately, which will assess acute heart failure, while chest X-ray may take some time to be performed. And we said that together with the clinical exam, EKG, BNP, you should start IV therapy, vasodilators, and diuretics, and reassess your patient. Then again, in those patients here, hemodynamically stable, please do not use any inotropes. But some people are still using inotropes in those patients. And I'm showing you here some meta-analysis that we did to try to convince people who are still using inotropes in patients who are hemodynamically stable, convinced that inotrope is a decongestive therapy, just to show them that vasodilators is as decongestive therapy as inotrope. In this paper, for the first time, we pull back all the paper ever published with acute heart failure and S1 and you can see here, every circle is a study. The larger is the circle, the larger are the number of patients in the study. You can see here we put cardiac index. Here in red we have wedge pressure. Then you see that the large majority of patients indeed had acute heart failure with a very high wedge pressure, more than 25. Then clearly patients coming with pulmonary edema related to acute heart failure. And you can see, by the way, that there is also a right ventricular dysfunction or right ventricular congestion in patients coming with acute heart failure and pulmonary edema, and you see that their central venous pressure is around 12 or 15. And again, in this meta-analysis, what we did, we checked for both wedge pressure and right atrial pressure. We compared inotropes in red and vasodilators in blue. And you can see for both wedge pressure and right atrial pressure, the decrease in wedge pressure and the decrease in right atrial pressure is really similar between vasodilators and inotropes. Then both are improving decongestion by the same way, and there is no reason why we should give an inotrope to decongest. Vasodilators are doing as well. However, we have side effects, and this is a paper that we published in intensive care many years ago, in more than 5,000 patients from all around the world with almost no cardiogenic shock. You see here that close to 15 to 20% of the patients got inotropes, although they were hemodynamically stable. And indeed, giving inotrope to those patients, even with a propensity score and several analyses, was associated with a higher rate of in-hospital mortality. To try to confirm this study, I'm happy to show you for the first time here a paper that is almost accepted in European Journal of Heart Failure. This is the European Society of Cardiology database. Those patients, again, there is almost no cardiogenic shock, close to 7,000 patients. And here we compared the patients who received vasodilators, diuretics, and the patients, again, with no reason received inotropic agents, mostly catecholamines. And see again here, there is a higher in-hospital mortality. Again, we did the propensity score, we did many statistical tests, and giving inotropes was always associated, if there is no reason to give inotropes, with a higher mortality. And what is interesting, for the first time, we looked at 4 years follow-up on those patients who got inotrope, and you see that even 3 to 4 years later, there is still a footprint of patients receiving inotropes with a higher mortality compared to patients receiving vasodilators and diuretics. Then again, in patients coming with acute heart failure, pulmonary edema, hemodynamically stable, there is no reason to give inotropes except increasing side effects. Now let's go to the other category of patients that is hospitalized in our ICUs. This is patients that are hemodynamically unstable. And as we wrote in this paper, there are 2 categories of patients. One category with very low patients coming to ICUs. This is low output patients. Those are patients with a low cardiac output, but mostly congestive. But the large majority of patients coming to our ICU are cardiogenic shock. And today, at least in Europe and many continents, the large majority of patients coming with cardiogenic shock are patients coming with acute coronary syndrome. They need to go in emergency to the cath lab, and when the coronary arteries are treated, they are back to the ICU. Just to show you here what is the clinical signs of those patients. This is CardShock. This is a survey we did in 9 countries in Europe, in ICUs, only collecting patients with cardiogenic shock. As you can see here, they are truly cardiogenic shock, low systolic, diastolic blood pressure, heart rate. You see that cold periphery was present in 95%, lactate was high in 70% of the patients. What should we do to treat those patients? Then I came back to the ESC guidelines published the last year. Then we can give inotropes, butamine, dopamine, levosimendan, phosphodiesterase, and I will come later to vasopressors. And again, we clearly said in the guidelines, inotropes should be given only when there are clear signs of hyperperfusion despite adequate filling status. And those inotropes are there to increase cardiac output. Then again, in this category of patients, those patients with a hemodynamic instability, we measure cardiac output, it's low, then we can give inotropes. What is cardiogenic shock? Cardiogenic shock is mostly organ dysfunction. We have patients already with respiratory distress, acute kidney injury, and I'm going to focus in the next minutes on hyperperfusion and high lactate. In those patients, as recommended, by the way, by the ESICM guidelines published 3 years ago, we need to put an invasive blood pressure, we need to measure cardiac output, and if possible, SVO2 measures. And here, what we recommend is to start with inotropes as a first-line therapy, and then, if needed, to give vasopressors. Why did we say this? Inotrope first, and then vasopressors. And this came from a paper that we published a few years ago with Romain Piracchio. We collected 3 large databases of cardiogenic shock. Those are ALARM, EFICA, and AHEAD, cardiogenic shock hospitalized in ICU in Czech Republic, in France, and in our cohort, alarm 9 countries, we collected close to 1,000 cardiogenic shock. And we were surprised to see that, in fact, all around the world, hemodynamic impairment is managed by 2 ways. One, we have close to 40% of the patients that got mostly vasopressors, epinephrine, norepinephrine, or dopamine. And you see here, 40% of the patients did not get any inotrope, but they got vasopressors. And 60% of the patients got a combination of inotrope and vasopressors. And you can see that there are almost no patients receiving only inotropes. And clearly, in those category here of patients, the intensivists try to manage blood pressure, try to improve, restore blood pressure. And in this category, intensivists try to combine improvement in blood pressure together with improving cardiac output. Doing a propensity score showed in a cohort of patients with a very high mortality, you see that here in hospital mortality is exceeding 60 or 70%. Combining inotrope and norepinephrine was associated with a lower mortality compared to vasopressors alone, and this is on the pooled data, and with the propensity score, we could confirm the same result. Combining is better than vasopressors alone. Then coming back to the ESC guidelines, what do the guidelines say about vasopressor? A vasopressor should be giving really if there is a need to increase blood pressure after giving an inotropic agent. Then what should we give as a vasopressor? Should we give adrenaline? Should we give noradrenaline? Should we combine with an inotrope or not? And this is an analysis of the CardShock cohort that I present you earlier, again, 9 countries in Europe. And the data I'm going to present here are, again, cardiogenic shock only related to myocardial infarction. When we did the analysis to see whether there are differences between the use of epinephrine, adrenaline, or the use of vasopressors, we could show here that the use of adrenaline was associated with a much higher mortality than the use of noradrenaline or other vasopressors. However, you can see here that the combination of either levosimendan and norepinephrine or dobutamine or norepinephrine was associated with a lower mortality compared to epinephrine alone. But indeed, one can criticize, they are not the same patients, the indications are not the same, propensity matching doesn't help understanding all this. And then we use the biomarkers to try to understand why epinephrine is so harmful. And in this slide, you can see first here the hemodynamic comparison over 5 days between epinephrine in dark and norepinephrine in light. Here is mean arterial pressure, heart rate, and cardiac index. The idea of these 3 graphs here is to say that on our daily practice, it's impossible to differentiate hemodynamic improvement, whether the patient has epinephrine or norepinephrine. It's just impossible. Over 5 days, the improvement in mean arterial pressure, change in heart rate, cardiac index is exactly similar between norepinephrine and epinephrine. But probably the most important graph is here, is troponin between, again, epinephrine and norepinephrine over 5 days. Let's first look on norepinephrine, and you see that the patients, again, with cardiogenic shock related to acute myocardial infarction, you see that the level of troponin in patients with receiving norepinephrine remained constant all along the 5 days. And you can immediately see here the difference with epinephrine. You see that the troponin level was similar than those receiving norepinephrine in the beginning, and you see that in the first 48 hours, you see that troponin increased 5 to 10 times higher than the group of patients receiving norepinephrine. Then a much higher level of troponin with patients receiving epinephrine, a higher level of NT-proBNP, and a higher level of creatinine in patients receiving epinephrine compared to norepinephrine. Then again, coming back to our algorithm, cardiogenic shock related to acute myocardial infarction or decompensated acute heart failure, we advise inotropic first after measuring cardiac output and vasopressors if really you need to improve cardiac blood pressure. Now for right ventricular dysfunction, and really I advise you to look on this recommendation on acute right ventricular dysfunction that we published the last year. For right ventricular dysfunction here, what you need is to quickly improve organs perfusion, right coronary perfusion pressure, kidney or liver perfusion. And here we advise to first start with norepinephrine in emergency to try to increase blood pressure because central venous pressure, because the venous pressure is very high, and then, if needed, to increase, to give inotrope. It's just to show you the contrast between left ventricular dysfunction and right ventricular dysfunction. Again, I advise you to read that recommendations, and we explained the dose, and we explained how we should use norepinephrine in that condition. Again, inotropes, vasopressor, and we hope that the patient will be stable and we can quickly wean inotropes and vasopressors. But sometimes the patients are unstable, and then we need to use left ventricular assist device or ECMO. Then how are we going to assess those patients who are going to be to remain unstable and who may need a more aggressive therapy in the next days? And this again is opening the lecture that you will hear later from Alain Combe. Again, on those patients, and I'm sure you share all those clinical data with me, it's impossible to say with a so low systolic blood pressure, diastolic blood pressure, heart rate, lactate, which one will survive and which one will not survive. And I'm happy to show you here this paper that just came online a few days ago in critical care medicine, where for the first time we measured a combination of two biomarkers at admission and the following 5 days to try to see how we can, as early as possible, try to assess the risk of the patient and whether the patient is going to survive with inotropic agents, with catecholamines, or he may need some more aggressive therapy. And we combine two biomarkers, one known in the myocardial infarction named ST2, and the other one is a more classical marker, is NT-proBNP. What we did here, every 12 hours in those patients with cardiogenic shock, we first measure ST2. And you can see here that within 12 hours after admission, the ST2 in the plasma was much higher in the patients who are going to die compared to the patients who are going to survive, and this will stay like this for the next 9 days. And looking on the NT-proBNP level, which is a marker of a function of the heart, you see here again that within 12 hours we already have a much higher discriminative level, by the way, of NT-proBNP in those who are not going to survive compared to those who are going to survive. How can we discriminate between those who are going to die or to survive? This is what we name the AUC. The higher is the AUC, the more it discriminates. First, our big surprise was to see that troponin was not so good discriminator. You see that troponin was really here around 70.7. You see that ST2 did well, NT-proBNP did also well, but the best was indeed the combination with an AUC that was quickly higher than 85%. The best way to show you the data are this way here. We have on the y-axis 30-day mortality or in-hospital mortality, which at the end of the day, this is what is interesting for us. And here you see over 5 days. In fact, you can measure those biomarkers at any time as soon as the patient is in your ICU and the results pops out positive 12 hours after admission. Then you can just start to measure few hours after admission. And you can see here rather clearly that starting 2 hours after the admission for cardiogenic shock, if the two biomarkers are below those thresholds, the mortality is very low, below 10%. If those two biomarkers are high, you see that the mortality is 80%, and this is true all along the ICU stay, but maybe most importantly, those biomarkers do much, much better than mean arterial pressure, heart rate, cardiac index, CVP, and lactate. Then just by measuring two biomarkers, you can really quickly say this patient is going to do well or this patient is going to die in the next days. Then again, the main message of my talk is maybe to say, please do not use inotropes in patients who do not need it. If patient comes hemodynamically stable, even with a big pulmonary congestion, kidney congestion, liver congestion. If he's stable, if you measure his cardiac output and it's fine, please start with diuretics, nitrates, non-invasive ventilations, but no inotropes. Giving inotropes in those conditions where the patient is hypoxic will only increase mortality. In patients with cardiogenic shock, whether it's related to acute myocardial infarction or not, first use inotropes, and if you need a vasopressor, please use norepinephrine. If there is a right ventricular dysfunction, a huge pulmonary embolism, first use norepinephrine. And all cases, but again, in cardiogenic shock, I didn't speak about septic shock, but I'm happy to answer during the questions what I think about septic shock. In cardiogenic shock and patients with ischemia, with coronary disease, please, no epinephrine in all cases. Thank you so much.